Afternoon all. I am Payal, working as a senior nursing officer in National Institute of Development. I am today's moderator for your session. Welcome to all of you who have joined this session. Good afternoon. It's really good to see you all. It's to see you all at Niti Nurses refers to eliminate TB in India. Before we start this session, let me give an overview how the nurses are benefited from this platform. First of all, nurses get benefited in terms of knowledge, upgradation, and skill enhancement via case discussions, sharing best practices. We are more aware and get to learn about management of TB develops and the capability to practice evidence measures. The interactive method of learning brings remarkable changes in knowledge and retention of nursing professionals. We have introduced the present didactics presentation, innovative learning technique, and case decision among folks, experts, lastly, the feedbacks. So this is the best platform for the live learning. Timely reminder about beginning of each session to the record of attendance and availability of didactics of almost each sessions. This platform is made exactly simple and user-friendly for each partner. It can be seen lot of participants learning and joining this session. Can you say from which state are you from? Great to see you all. Welcome everyone. Before we before we move on to today's session, let's have a short intro of our dynamic team members here. We have with us our nursing superintendent ma'am, Mrs. Anita Rani Kansal from our institute and ITRD. She is a case expert today. She has been recognized by the ICM TV MDR TV projects as a leading light in recognition of her outstanding contribution to the care of people affected by TB. Before we move on in forward, it requests to mute your microphones so there is no distractions from the background noise and can enable it whenever required. Anticipated physical and technical interruptions like connections, errors, freezing, tagging, or all sorts of problems with patients. We are not in the same meet room, so try not to multitasking between the sessions. Welcome, ma'am. We have a case, Director ma'am, Dr. Manpreet Bhalla. We would like to welcome Dr. Manpreet Bhalla, our esteemed director of institution, and wish to have few encouraging words from them. Just not. Neeta Rani, Council ma'am, please say a few words and encourage us.
Yeah. Ma'am, we can't hear you. Anita ma'am. Ma'am, we still cannot hear you. Ma'am, could you please check your mic because we cannot hear you. Sorry, ma'am, we still cannot. Ma'am is coming to the hub. Just wait for that. Introduce them.
Hello, good morning, everybody. I welcome all the participants who have joined, and I welcome Dr. Shalini Malik, who is the case expert today, and she has prepared time for us. I, from all of the nurses of our institute and the participants, welcome her. And she is Professor Shalini Malhotra, and she is in the Department of Microbiology at the Dr. RML Hospital, and she has worked for 25 years and her expertise in the infection control, mycology, HIV, BMW, and she has prepared the guidelines and she acts as a guide for the postgraduates and PhD students. And she has done more than 100 publications, national and international, and she is a reviewer of the many indexed journal. So I welcome her, and I think all the participants will be able to have her expertise here. And now I hand over the mic to Miss Ekta Goswami, who is the presenter today. Thank you.
Okay, good afternoon to one and all here. So in today class, we will discuss about the VAP, ventilator associated pneumonia. The before starting my topic, I would like to introduce the objective, introduction, define VAP, case history, risk factors, pathogenesis of VAP, criteria for diagnosis, and prevention by VAP control. So in introduction, half of all cases of hospital-acquired pneumonia is ventilator-associated pneumonia. VAP is a type of hospital-acquired pneumonia. It is the second most common nosocomial infection in the ICU. After the POTI, it is the second most common nosocomial infection. It is a type of nosocomial infection. 50% of antibiotics administered in ICU are treatment of VAP. The mortality of the VAP between 33 to 50%, which result in adverse health outcomes, increased healthcare costs, and increased demand on medical resources. Now we will discuss the case history. A 16-year female child admitted in our hospital on 18/3/24 with a complaint of shortness of breath since 2 weeks, which increased since 5 to 6 days, and with the productive cough since 1 month, which is whitish, thick, and non-foul smelling, no blood taste, and fever since 1.5 months, with chills and rigor. On the examination findings of the patient was conscious and oriented, SpO2 82% on room air, pulse rate 110 breath per minute, BP 100 by 60 mmHg. On examination of cardiovascular system, S1 and S2 present, and CNS system, no abnormalities were present. Then patient condition suddenly deteriorated and patient become drowsy with SpO2 65%. Patient put on ventilator with PRVC mode 100% FiO2. Then the patient was shifted to ICU from emergency for further management. Now the investigation. All culture were sent on 19/3/24, including blood and urine X-rays also. All routine CBC, LFT, KFT, viral marker also sent. Culture reports were sterile on 21/3/24. TLC count is 11.1 K as on 21/3/24. The treatment injection Pipso 2.25 gram IV QID, injection Ciplox 400 mg IV BD, injection Rentec 150 mg IV BD, injection hydrocortisone 50 mg QID, then NAV Astalin plus Ipravent QID, RT fit 200 ml 3 hours. On the 23/3/2024, TLC was raised up to 26,000. Patient has fever with chills with altered WBC count, increased ET secretions, chest X-ray shows chest infiltration. Again, the culture repeated and CT ET culture report Klebsiella pneumoniae. Antibiotics were revised based on the culture reports. Injection polymyxin B IV BD, injection vancomycin 500 mg IV BD. Now a patient come into the diagnosis criteria for VAP. This is the definition of ventilator-associated pneumonia. Pneumonia that occur more than 48 hours to 72 hours of thereafter following endotracheal intubation, which is characterized by the presence of a new or progressive chest infiltrate, sign of symptom systemic infection like fever, altered WBC count, change in sputum characteristic, then detection of a causative agents. Then this is the new another one criteria for defining VAP according to the CDC surveillance. Radiographic infiltrate, a new or progressive infiltrate that persists for more than 48 hours. And sign and symptom, at least one of the following: fever of more than 38 degree or less than 36 degrees Celsius, blood leukocytes count of more than 10,000, or less than 5,000 cells per ml. Pleural tracheal secretions. Then the lab findings, at least one of the following an organism identified from blood or pleural fluid. A positive culture from BAL or endotracheal aspirate. A BAL is a sterile procedure in which we have to take the fluid from the lungs for the lungs pathology to diagnose any lung pathology or histology. At least 5% of bile sample obtained cells contain intracellular bacterial on a gram scale. Now we will discuss the risk factor of WAP. There are two types of risk factor, endogenous factors and exogenous factors. In endogenous factor, the first one is advanced age. If the patient is more than 60 years, then impaired consciousness, upper respiratory tract colonization or sinusitis, and gastric colonization. If the patient is any immunocompromised status, if the patient immunity is very low, then pre-existing habits, illness like cigarette smoking and COPD. In exogenous factor, reintubation of the patient and the prolonged intubation, then frequent ventilator circuit changes and nasogastric tube feeding, enteral feeding, frequent movement of patient out of ICU, improper hand hygiene, use of excessive sedatives, paralyzing agent or H2 receptors blockers. This is the now we will discuss the pathogenesis of VAP. The pathogen factors which can lead to colonization of oropharynx and nasal sinus, which can lead to pooling of secretion above tracheal tube curve. Then micro aspiration of secretion past the curve, which can lead to tracheal injury by tracheal tube. Then the colonization of upper respiratory tract, which can lead to ventilator associated pneumonia and biofilm formation inside the tracheal tube. This is the biofilm formation which and lung affected by the VAP. Now the criteria for diagnosis. There are no standard criteria for the diagnosis of ventilator associated pneumonia, but typical 3 or more of the following are required, like fever, leukocytosis, pleural secretion, and infiltrate on chest radiography. Now we will discuss the WAP bundle. WAP bundle was proposed in 2005. Bundle means it's not a single intervention. It is a set of evidence-based intervention that when implemented together for all patients on mechanical ventilation. WAP bundles can be effective in reducing mortality, hospital stays, medical costs. The WAP bundle should be effective. WAP bundle must be evidence-based. The bundle should be evidence-based, maintained, and accepted by the ICU personnel. At every step, nurses play an important key role in infection control, like prevent colonization. If we prevent the first step, then another step automatically stops. Then prevent aspiration, minimizing duration of ventilation, ET suction and humidification, and general measures. Now we will discuss one by the one WAP bundle components. There are 5 components in WAP bundles. The first one is elevation of head of the bed. The second one is daily oral care with chlorhexidine. Then third one is peptic ulcer disease prophylaxis. Then fourth one is deep vein thrombosis prophylaxis. Then fifth one is daily sedation vacation and assessment of readiness to extubate. So I will explain the first bundle. Head and elevation of the bed 30 degree to 45 degree in semi-recommended position, which can help in prevent aspiration of gastric contents, and semi-recommended position 45 degree, then supine reduce back from 8% to 34%. The second one, our bundle is WAP bundle, oral care with chlorhexidine. Protected epithelial is susceptible to colonization by these pathogenic organisms. So we have to oral hygiene thrice daily minimum, which can help the protective fibronectin cover the oral epithelial and prevent gram-negative enteric pathogens from adhering to the underlying epithelial cell. Oropharyngeal secretion contain these organisms can be aspirated. The third one is our WAP bundle is peptic ulcer prophylaxis. Stress ulcer prophylaxis may or may not have a direct impact on VAP rates, but impact associated risk factors that are related to patient being treated with mechanical ventilation in the ICU, which help in reduce acid production in stomach and the affect risk of bleeding from gastric erosion and peptic ulcer. So we have to reduce the risk of bleeding from gastric erosion and peptic ulcer. We use the peptic ulcer prophylaxis. The fourth one is deep vein thrombosis DVT prophylaxis. Complication of mechanical ventilation due to increased venous stasis in the lower extremities. Prophylaxis of DVT reduce the incidence of venous thromboembolism, use of anticoagulant and stockings, and sequential compression devices, which can change in every 8 hourly, and see the any observe for any skin changes, which help in reduce potentially clot formation and reduce potential for pulmonary embolism. The last one is daily vacation sedation. Vacation means don't give the unnecessary sedation to the patient and check the assessment to readiness to extubate, because lightning sedation daily at an appropriate time to access for neurological readiness to extubate. Spontaneous breathing trial. We have to give the with the permission of the doctor. We check the spontaneous breathing trial and include precautions to prevent self-extubation such as increased monitoring and active vigilance during the trial, which can help in early discontinuation of invasive devices and initiation of NIV help in prevention of that. Now the other general measures we can use the in to prevent the VAP. Hand hygiene, use of hand rub, soap and water, with soap and water, strict hand hygiene and asepsis before and after. If we are assisting for the intubation in the patient, so we have to use the strict hand hygiene. If we are doing the suctioning of the patient, so we have used strict hand hygiene with the proper movements of the hand, and collecting ET aspirate specimen and investigation. And use inline suction device, closed suction catheter. Better than open suction, we have to follow the closed suction if available and possible. Perform subglottic suctioning. Fourth hourly. Drainage of secretion that pool above the ET cuff below the vocal cords, it potential source of pathogens. Only sterile fluid for suctioning. Avoidance of frequent change of ventilator circuits. Don't change the circuits unnecessary. Change of circuits only when found faulty or visible soil, because increase manipulation of ventilator tubing cause contaminated secretion to the enter lungs via the endotracheal tube or lumen. And maintenance of cuff pressure above 25 centimeter of H2O, and maintain cuff pressure every shift. Monitor cuff pressure every shift. Use of HME filter, heat moist exchange filters, because help in prevention of micro aspiration. Moisture content in heated humidifier may serve as a growth media for organism. And always emptying the water trap in the collection of water in ventilator circuit. So always observe the ventilator circuits, if any water trap, so always time to time it should be empty. Now some nursing intervention for the prevention of VAP. Note any change in characteristic of secretion like color, quantity or odor, new onset of fever, tachypnea. If there is any sign and symptom is there, so you have to report to physician immediately. Administer prescribed antibiotic on time. Perform appropriate assessment on patient readiness for weaning. Maintain optimal nutrition status and glycemic control for the patient. Observe for tube misplacement. Always see the check the tube misplacement marking at lips, teeth and nail after X-ray confirmation, especially after position change. So you have to check the tube misplacement when the transferring patient and prevent accidental extubation by taping tube securely, and restraining to the patient, sedating as needed. Assess for pain, because pain may prevent patient from coughing and deep breathing. Now there is a mnemonic which can we always remember: choose no VAPs. There is a C stand for curve pressure between 25 and 30 centimeter of water, S2O. Then H stand for head and elevation, 30 to 45 degree. And O for oral care with chlorhexidine. Then another O is oral antral feeds. Then S for suction when indicated. E for ET tube for subglottic suction. Then N for no saline lavage. Sometimes we are using the saline during the suctioning. So it can increase the respiratory secretion of the patient, which can worsen the condition of our patient. So it should be avoided. O oral intubation if possible. B for no indication for regular change of ventilator circuits. A for amware. P for please wash hands. S for titrate sedation and analgesic. This is the take-home page, prevent WAP and HAP. The application of WAP bundle is very challenging. So early weaning, W for weaning and H stand for hand hygiene, A for aspiration precautions, P for prevention of contamination. This is take-home page for all of us. Nurse can lead the commitment to reducing WAP and improving quality of care by coordinating and implementing these evidence-based practices. So we have to prevent colonization, then prevent aspiration, minimize duration of ventilation, ET suction humidification, and general measure, and choose zero WAP. So thank you to all of you.
Thank you so much, Ekta.
Dr. Shalini.
Welcome, Shalini ma'am. We would like to have an expert advice from you on the and enlighten us with your knowledge, ma'am.
Yes, thanks for inviting me to this interesting discussion. And I must congratulate Ekta for an elaborative discussion that she has taken. She has almost covered each and everything here. I would just like to make some comments to what she has said because more or less the topics have been covered. I just need to reinforce what she has said. So, firstly, I would talk about the definition. The definition has rightly covered by her. We must understand that unless we know how to identify a VAP, we cannot make any measure to control it. When we talk about VAP bundles, it's important for us to know what are the VAP rates. So for that definition point, as Ekta has covered, so it would be easy for us to remember if whatever points she has said, if we try to classify them into ABC. So we must remember whenever we are talking about a surveillance definition for VAP. Remember when we are talking about a surveillance, that is for knowing what is the rate of VAP. And a clinical definition is what a clinician in the ICU and a person from anesthesia or whosoever is looking after the patients admitted there is how he defines it and how he treats the VAPs there. Okay. So right now here, as looking at what Ekta has covered, we are pertaining to the surveillance definition. So it would be easy for all of you to remember that whenever we are defining a VAP, we must remember A plus B plus C. If all these criteria fulfill, then only we define it as VAP. So as rightly pointed out by Ekta, that A would be the radiological evidence, B would be the clinical evidence, and B also has been divided into B1, B2, where we look for temperatures and different clinical signs and symptoms in the patient as rightly defined by Ekta. And C is what we get in the lab. So that would be a documentation of what has been infecting the respiratory system of the affected individual. So that is about the definition. And I was just listening to what Ekta was covering. So she said that we need to have a comprehensive coverage of the VAP bundles. And if you look at the definitions and if you look at the VAP bundles, I feel that it calls for an interdepartmental coordination. That is the key to controlling any hospital-acquired infection. So there should be a good coordination between the lab, between the ICU people, and between the physicians for controlling VAP. Sitting in the ICU, sisters or doctors cannot control the infection themselves unless they have a support from the lab and they know what kind of organisms they are isolating. Similarly, what the clinician is going to treat would depend on the lab report, that what is the sensitivity of the organism that they have to take. Like in this particular case, she mentioned that the patient came on 18th and the samples collected on 19th were all negative. So then again, the samples were taken and then they got a positive lab report, and then accordingly they changed the empirical to the treatment what was as per the maybe that was as per the lab report that they obtained. So that is why it's very important for all of us to realize that all the stakeholders, whether it is doctor, whether it is nurse, whether it is lab people, or whether it is physician, all of us have to work in coordination. Third point I need to pinpoint, hand hygiene plays any bundle, whether it is a VAP bundle, or we talk about a Corti bundle, or we talk about a CLAPSI bundle. I think hand hygiene is key to any infection control measure as far as the hospital-acquired infections go. And in this presentation, you have used beautiful mnemonics for VAP bundles. So just to add on to that list, it would be easy for all of you to remember. If we go to the steps of hand hygiene, what we do in our hospital, we teach all our nursing staff and the workers and all a simple mnemonic and the doctors to remember Suman K. Have you heard? I don't know if you people have heard about this, but this is a very simple way of remembering the 6 steps of hand hygiene as given by WHO. So S stands for Sida, U stands for Ulta, M stands for Mutti, and then A stands for Angutha, and N stands for your nails, and then we do the Kalai K. So that is another addition to the mnemonics, which can be easily used and easily taught to all of us. And last but not the least, you have beautifully covered the bundles, but these bundles, unless and until we train the people who are working in the ICUs for these device-associated infections, it just stays on the paper. So it's very important, just the way you're holding this session, similar more sessions should be held, practical demonstrations should be there to train all the people, including the workers in the hospital, how they're going to maintain the cleanliness, how they are going to do the disinfection, how the instruments are being sterilized. Like you spoke about the ventilator circuits having the condensation water and all. So all that, it should be a practice for all the nurses and all the doctors when they go for round, or in every shift when they go for giving the medicines and all the devices which are there should be examined thoroughly before we leave the patient bed and perform hand hygiene checkup. Thank you so much.
Thank you so much, ma'am, for the expert advice. Anybody would like to have any queries? Please, participants. Please, our experts are here. They'll help you if there are any queries, any questions.
Chat में एक बार wait.
You can write on chat.
तो मंत्री कौन है? अगर है तो देख लो, बुला लो. We can close the session.
Can you
Can you revise the hand washing steps? Okay, that ma'am Shalini has explained the mnemonics for the hand washing. That is Suman K. Suman K means Sida, Ulta, Mutti, Angutha, nails, and kalai. That is Suman case. That is easy to remember the steps of hand washing. Any other question?
Any other questions? Any other queries? Please come forward and ask, please. Is there any?
Ma'am Shalini would like to answer, ma'am.
Yeah, can you just tell me the question? I didn't see the chat box, sorry.
Okay, ma'am. That is there any particular number of days after which we will consider the VAP for a patient?
Yes, definitely. So whenever we talk about any device-associated infection, as per the definitions of hospital-acquired infection, the person should be on that device for more than 48 hours. So anything beyond 48 hours would be considered as VAP after the intubation of the patient. But anything before that, like in this case, the first volley of samples that were collected were on the second day. That is, the patient was admitted on 18th and 19 the samples were collected, and luckily there was no organism isolated. But had there been any growth in those organisms, then this case would not have been considered as a case of hospital acquired VAP, because then the duration would not have sufficed. But later on, when the sample was, I think, collected on 21st, 48 days were already passed. So remember, when we count the 48 hours criteria, it is the day one would be when the patient has been put on a device, and 48 hours when we collect the sample, that would be the day of the sample collection taken into consideration and not the reporting time.
Okay.
Because at one of the presentations, she had said that on so-and-so date, the report was like that. We don't have to we don't have to consider the date when the report was generated. For us, it is important that the date when the patient was intubated and the date when we collected. So the sample should be collected. I mean, if it is required, the samples can be collected before, but if we have to define as per a hospital acquired or a VAP, we have to define, then the sample collection has to be considered after 48 hours of admission. So that is important.
Thank you, ma'am. Ma'am, there is another question in the chat box that is about the deep vein thrombosis prophylaxis.
Yes.
So, what all are the steps that the one of the participant is asking? What all can be done under the deep vein?
I think she has already mentioned the usage of stockings, and we have to give anticoagulants to the patients depending on the other comorbidities, whether the patient is having any cardiac incidents beforehand or something like that. So we can start anticoagulants, and we can use the stockings that have already been mentioned, and we have to use repositioning of the patient in every shift. So these are the measures by which the DVT can be prevented.
Yes, ma'am. Thank you.
Thank you, ma'am.
Any other question? Any other question? If the participants have. So I think there is no question. Thank you so much, ma'am, for being with us, for taking queries of our participants and sparing your valuable time. Thank you so much, ma'am.
Thank you for making me a part of this important discussion.
Thank you. Thank you, Shifa, also. She takes all the efforts behind the curtains.
Thank you all, and feedback link is posted in the chat box, so you all are requested to share your feedback of the session before you leave. And in the meantime, if you have any question, you can write in the chat box. The presentation has been uploaded in the content section, so you can have access to that. I'll keep the session running for another 2 minutes. Till then, please fill the feedback form, and after that, we close it. Then closing remarks.
Thank you so much. Thank you so much for participating and and attending the session. Is there any query? You can ask in chat box.
Okay, Dr. Manpreet won't be able to join, so we can. Thank you. So we wind the session here. So thank you, everyone.
Thank you. And I'll keep the session running for another 1 minute. Till then, please share your feedback and ready. you next month.